The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Continuing Medical Education, ACCME, to provide continuing medical education for physicians. The Centers for Disease Control and Prevention designates this enduring material for a maximum of 0.75 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Centers for Disease Control and Prevention is accredited as a provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This activity provides 0.5 contact hours. The Centers for Disease Control and Prevention is authorized by IACET to offer 0.05 CEUs for this program. The Centers for Disease Control and Prevention is accredited by the Accreditation Council for Pharmacy Education as a provider of continuing pharmacy education. This program is a designated event for pharmacists to receive 0.05 contact hours in pharmacy education. The universal activity number is 0387-0000-16-190-H04-B. Category. This activity has been designated as knowledge-based. Once credit is claimed, an unofficial statement of credit is immediately available on TCE Online. Official credit will be uploaded within 60 days on the NABP/CPE monitor. The Centers for Disease Control and Prevention is a pre-approved provider of certified in public health CPH recertification credits and is authorized to offer one CPH recertification credit for this program. CDC is an approved provider of CPH recertification credits by the National Board of Public Health Examiners. Effective October 1st, 2013, the National Board of Public Health Examiners, NBPHE, accepts continuing education units, CEU, for CPH recertification credits from CDC. Please select CEU as your choice for continuing education when registering for a course on TCE Online. Learners seeking CPH should use the guidelines provided by the NBPHE for calculating recertification credits. For assistance, please contact NBPHE at http://www.nbphe.org. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, content experts, and their spouses, partners wish to disclose that they have no financial interest or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed the content to ensure there is no bias. Content will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception of the content experts' discussion on influenza vaccines. Content experts will be discussing the use of influenza vaccines in a manner recommended by the Advisory Committee on Immunization Practices, but not approved by the Food and Drug Administration. CDC did not accept commercial support for this continuing education activity.
Welcome to Influenza Vaccination Recommendations 2016-2017. During this program, we will describe the Advisory Committee on Immunization Practices influenza vaccine recommendations, describe the benefits of influenza vaccination, describe best practices for influenza vaccine storage, handling, and administration, describe disease detection and health care services to prevent health problems and maintain health, including smoking cessation, weight reduction, diabetes and blood pressure screening, and immunization services. Influenza is an infectious viral disease that can cause serious illness and even death. In any given year, it is estimated that millions of people in the U.S. are infected with an influenza virus. The incubation period for influenza is usually 2 days, but varies from 1 to 4 days. Classic influenza illness is characterized by the abrupt onset of fever, myalgia or muscle pain, sore throat, non-productive cough, and headache. Additional symptoms may include rhinorrhea or runny nose, headache, substernal chest burning, and ocular symptoms such as eye pain and sensitivity to light. Children are more likely than adults to have nausea and vomiting. The most frequent complication of influenza is pneumonia, either as a direct viral infection of the lungs or a secondary bacterial pneumonia, most commonly caused by Streptococcus pneumoniae or Staphylococcus aureus. Other possible serious complications triggered by influenza can include inflammation of the heart, brain, or muscle tissues, and multi-organ failure, for example, respiratory and kidney failure. Influenza virus infection of the respiratory tract can trigger an extreme inflammatory response in the body and can lead to sepsis, the body's life-threatening response to infection. Most cases will cause 3 to 7 days of illness, but will resolve without the need for medical care. However, the severity of influenza illness depends on factors such as a person's age, health status, prior immunologic experience with influenza viruses, and the influenza virus causing the infection. The risk for complications and hospitalizations is higher among persons 65 years of age and older, children younger than 5, persons with certain chronic diseases such as heart or lung disease or diabetes, pregnant women, and American Indians, Alaska Natives. While it varies, the nationwide impact of an influenza season can be devastating. From the 1976-1977 through the 2006-2007 season, estimated influenza-associated deaths range from a low of about 3,300 to a high of about 49,000. Following the 2009 pandemic, population-based surveillance data for 2010, 2011 through 2014-2015 estimated that influenza was associated with 114,000 to 633,000 hospitalizations and 4,900 to 28,000 deaths per year. Among these, about 50 to 70% of hospitalizations and about 70 to 90% of deaths occurred among adults 65 years of age and older. This pattern can change depending upon which flu viruses are circulating. CDC recommends vaccination as the best way to prevent influenza. Vaccination can reduce the number of illnesses and prevent serious outcomes like hospitalization. Usually, vaccine effectiveness is approximately 50 to 60% when the circulating viruses are well matched to the viruses recommended for vaccine production. Influenza vaccines protect against 3 or 4 different influenza viruses, depending upon which vaccine formulation is administered. It is especially important for persons at high risk of serious influenza-related complications and for those who have close contact with them, including healthcare personnel. During the 2015-2016 influenza season, CDC estimated the available vaccines were about 47% effective in preventing laboratory-confirmed influenza illness. These effectiveness estimates measure the reduced risk of a person getting sick and going to the doctor compared with that of an unvaccinated person. Therefore, for the 2015-2016 influenza season, CDC estimates found the available vaccines were nearly as effective as is usually found with a well-matched vaccine. CDC is optimistic that the 2016-2017 vaccine will offer good protection against the flu during this influenza season. 2 of the vaccine virus components from last season, the influenza A H3N2 virus and the influenza B virus, were updated for the 2016-2017 vaccine. The Advisory Committee on Immunization Practices, or ACIP, has published recommendations for the use of seasonal influenza vaccines for the 2016-2017 season. For an overview of the recommendations, we spoke to Dr. Lisa Groskopf, with the Influenza Division of the National Center for Immunization and Respiratory Diseases.
Routine annual influenza vaccination is recommended for all persons 6 months of age and older who do not have contraindications. Optimally, vaccination should occur before the onset of influenza activity. Healthcare providers should offer vaccination by the end of October if possible. Vaccination should continue to be offered as long as influenza viruses are circulating in the community. The 2016-2017 U.S. licensed trivalent influenza vaccines contain hemagglutinin derived from an A. California 7, 2009 H1N1-like virus, an A. Hong Kong 4801, 2014 H3N2-like virus, and a B. Brisbane 60, 2008-like virus from the Victoria lineage. Quadrivalent influenza vaccines contain these vaccine viruses and a B. Phuket 3073, 2013-like virus from the Yamagata lineage. Various influenza vaccine products are available for the 2016-2017 season, including 2 new vaccines. The first is Flucelvax Quadrivalent, which was licensed in May 2016 for persons 4 years of age and older. It is prepared from virus propagated in canine kidney cells rather than in eggs. This quadrivalent formulation replaces the trivalent formulation of Flucelvax. The other new vaccine, Fluad, was licensed in 2015 for persons 65 years and older. It contains an adjuvant, MF59, which is designed to improve the immune response to the vaccine in older persons. You can find a table listing available products online. Inactivated influenza vaccines, abbreviated as IIV, are available as trivalent and quadrivalent products. Recombinant influenza vaccine, abbreviated RIV, is available as a trivalent product. Age indications vary by product, formulation, and presentation. In cases where more than one type of vaccine is appropriate and available, ACIP does not express a preference for use of any particular product. Because of concerns regarding effectiveness against influenza A H1N1 PDM09, ACIP made the interim recommendation that LAIV not be used in any population during the 2016-17 season. Although not recommended, LAIV is still a licensed vaccine that might be available during 2016-17. Severe allergic and anaphylactic reactions can occur in response to various influenza vaccine components, but such reactions are rare. With the exceptions of the recombinant influenza vaccine, Flublok, and the cell culture-based inactivated influenza vaccine, Flucelvax, influenza vaccines are prepared by propagation of virus in embryonated eggs. For the 2016-17 influenza season, ACIP recommends that persons with a history of egg allergy who have experienced only hives after exposure to egg should receive influenza vaccine. Any licensed and recommended influenza vaccine may be used as long as it is otherwise appropriate for the recipient's age and health status. Persons who report having had reactions to egg involving symptoms other than hives, such as angioedema, respiratory distress, lightheadedness, or recurrent vomiting, or who required epinephrine or another emergency medical intervention may also receive any licensed and recommended influenza vaccine that is otherwise appropriate for the recipient's age and health status. For these latter persons, the selected vaccine should be administered in an inpatient or outpatient medical setting, such as a hospital, clinic, health department, or physician office. In these instances, vaccine administration should be supervised by a healthcare provider who is able to recognize and manage severe allergic conditions. A previous severe allergic reaction to influenza vaccine, regardless of the component suspected of being responsible for the reaction, is a contraindication to future receipt of the vaccine. During their first season of vaccination, children 6 months through 8 years of age require 2 doses of influenza vaccine administered at least 4 weeks apart. There are also instances where some children in this age group who have previously received influenza vaccine will also need 2 doses. For the 2016-17 season, children 6 months through 8 years of age who have previously received a total of 2 or more doses of trivalent or quadrivalent influenza vaccine before July 1, 2016, require only 1 dose. The 2 doses do not need to have been administered during the same season or consecutive seasons. For children in this age group who have not previously received a total of 2 or more doses of trivalent or quadrivalent influenza vaccine before July 1, 2016, 2 doses administered at least 4 weeks apart will be required. The first dose should be given as soon as possible after vaccine becomes available. A flowchart to assist healthcare personnel in determining the number of doses needed is available online. ACIP recommends annual influenza vaccination for all persons 6 months of age and older. But when vaccine supply is limited, vaccination efforts should focus on certain persons. These persons include all children 6 through 59 months of age, all persons 50 years of age and older, adults and children with certain medical conditions, those with chronic pulmonary disorders, including asthma, cardiovascular disorders except hypertension, and those with renal, hepatic, neurologic, hematologic, or metabolic disorders, including diabetes mellitus. Persons with immunosuppression, including immunosuppression caused by medication or HIV infection, women who are or will be pregnant during influenza season, children and adolescents 6 months through 18 years receiving long-term aspirin therapy and who might be at risk for experiencing Reye syndrome after influenza virus infection, residents of nursing homes and other long-term care facilities, American Indians, Alaska Natives, and persons who are extremely obese with a BMI of 40 or greater. Because pregnant and postpartum women are at higher risk for severe illness and complications from influenza than women who are not pregnant, ACIP recommends that all women who are pregnant or who might be pregnant in the 2016-2017 influenza season receive IIV. Influenza vaccination can be administered at any time during pregnancy, both before and during the influenza season. Persons who live with or care for persons at high risk for influenza-related complications should also be a priority for annual influenza vaccination when vaccine supply is limited. These persons include healthcare personnel and household contacts, including children, and caregivers of the persons discussed earlier at increased risk of influenza complications, and those in contact with children less than 6 months of age. The full recommendations and additional resources, including patient education materials, are available at www.cdc.gov/flu. Healthcare personnel continue to demonstrate their commitment to combating influenza disease. As more influenza vaccines become available, immunization providers will have more types of vaccine to choose from for their patient population.
In this section of our program, we will focus on questions about influenza vaccine storage, handling, and administration.
Let's address some of the most frequently asked questions from healthcare personnel. What are CDC's recommendations for storing influenza vaccines? CDC recommends storing influenza vaccines in a purpose-built unit specifically designed for storage of biologics, or if necessary, a standalone household refrigerator. These units can vary in size from compact, under-the-counter styles to full-size units. If a household combination refrigerator-freezer is used to store vaccines, CDC recommends using only the refrigerator compartment for vaccine storage. A dormitory or bar-style refrigerator-freezer unit should never be used to store any vaccine, including influenza vaccine. These units have been shown to pose a significant risk of freezing vaccines, even when used for temporary storage. Using dormitory-style units to store vaccines for the Vaccines for Children program or other vaccines purchased with public funds is prohibited. At what temperature should influenza vaccine be stored? All influenza vaccines should be stored in the refrigerator between 2 and 8 degrees Celsius or 36 and 46 degrees Fahrenheit. What type of thermometers should be used for measuring temperatures in a vaccine storage unit? To ensure vaccines are within the appropriate temperature range, CDC recommends a continuous monitoring and recording digital data logger with a current and valid certificate of calibration testing, also known as a report of calibration. At a minimum, the device should record the temperature every 30 minutes. What are the vaccine storage recommendations when conducting off-site or satellite facility influenza vaccination clinics? Vaccines that will be used at an off-site or satellite facility should be delivered directly to that facility. If that is not possible, transport vaccines using a portable vaccine refrigerator with a temperature monitoring device placed with the vaccines. If this equipment is not available, containers and supplies specifically designed and tested for transporting vaccines can be used with a temperature monitoring device. If vaccines must be transported, transport only what is needed for the workday. The total time for the workday, including transport time, should be a maximum of 8 hours. If you must transport vaccines in a non-commercial vehicle, use the passenger compartment, not the trunk. Immediately upon arrival at an off-site or satellite facility, vaccines should be stored in an appropriate storage unit with a temperature monitoring device, and the temperatures should be read and recorded a minimum of 2 times during the workday. If vaccines cannot be stored in an appropriate storage unit while at an off-site or satellite facility, they should be kept in the portable vaccine refrigerator that was used to transport them. While at an off-site or satellite facility, staff should place a temperature monitoring device, preferably with a probe in a thermal buffer, as close as possible to the vaccines. Read and record temperatures at least hourly. Keep the container closed as much as possible, and each staff member administering vaccines should remove only 1 multidose vial at a time for preparation and administration. A checklist to assist with planning off-site influenza clinics is available online. Additional information is available in CDC's Vaccine Storage and Handling Toolkit. How do you correctly interpret expiration dates on vaccines, including multidose vials? And do all flu vaccines expire at the end of flu season? No, all flu vaccines do not expire at the end of flu season. Although most influenza vaccines expire on June 30th, some expire during flu season. In addition, there can be confusion about expiration dates for multidose vials. Most influenza vaccines in multidose vials can be used through the expiration date printed on the label, as long as the vaccine is stored properly and not contaminated, or unless the manufacturer indicates otherwise. Sometimes the manufacturer specifies that once the multidose vial has been entered, meaning the rubber stopper has been punctured, the vaccine must be used within a certain number of days. This is commonly referred to as the beyond use date, or BUD. When using a multidose vial of influenza vaccine for the first time, check the package insert to determine if the vaccine has a BUD. If it does, calculate the beyond use date using the time interval found in the vaccine's package insert. Initial and label the vaccine vial with the BUD. Between uses, store multidose vials of influenza vaccine appropriately until the vial is empty or the beyond use date is reached. Any vaccine not used before the BUD should be discarded, even if there is vaccine left in the vial. Is it okay for a large clinic that administers a lot of flu vaccine to draw up vaccines at the beginning of the clinic day? Vaccine manufacturers do not recommend that vaccines be pre-drawn in advance. This is because general use syringes are not approved for use as a storage system for drug products. Therefore, CDC recommends using manufacturer-filled syringes for large immunization clinics. If vaccines must be pre-drawn, CDC recommends drawing up vaccine just before administration. Vaccines should not be pre-drawn before a clinic. Drawing up doses of vaccine days or hours before a clinic is not acceptable. At the clinic site, no more than one multidose vial should be drawn up at one time by each person administering vaccine. At the end of the workday, any remaining vaccine in the provider pre-drawn syringes should be discarded. Why does the FluZone package insert state that a maximum of 10 doses can be withdrawn from a multidose vial? Why has this been added? Because multidose vials typically contain a preservative to help prevent the growth of microorganisms, they can be entered or punctured more than once. The multidose vial of FluZone is licensed as a 10-dose vial for use in persons 6 months of age and older. Only the number of doses indicated in the manufacturer's package insert should be withdrawn from the vial. Children 6 months through 35 months of age receive a 0.25 ml dose. Persons 36 months of age and older receive a 0.5 ml dose. Whether the doses are 0.25 ml, 0.5 ml, or a combination of both, only 10 doses may be withdrawn from the multidose vial. After the maximum number of doses has been withdrawn, the vial should be discarded, even if there is residual vaccine and the expiration date has not been reached. All stability data and studies were done with only 10 punctures to the stopper. What are the routes of administration for influenza vaccines? Influenza vaccines are administered by 3 different routes: intramuscular, intradermal, and intranasal, though the use of intranasal vaccine, LAIV, is not recommended during the 2016-17 season. Most inactivated influenza vaccine products are administered by intramuscular, abbreviated IM, injection. There are 2 ways to administer vaccine by intramuscular injection. In most cases, IM injections of influenza vaccine are administered using a needle and syringe. One brand of inactivated vaccine, Afluria, may be administered by jet injector, but only to persons 18 through 64 years of age. Healthcare personnel should be familiar with the anatomy of the area where the vaccine will be injected. When administering influenza vaccine, there are only 2 routinely recommended sites for an IM injection. These are the vastus lateralis muscle in the anterolateral thigh and the deltoid muscle in the upper arm. Injection at these sites reduces the chance of involving neural or vascular structures. Because there are no large blood vessels in the recommended sites, ACIP states that aspiration before injection of vaccines is not necessary. The needle should be long enough to reach the muscle mass and prevent vaccine from seeping into subcutaneous tissue, but not so long as to involve underlying nerves, blood vessels, or bone. Guidance on recommended injection sites and needle selection can be found in ACIP's General Recommendations on Immunization and in the book Epidemiology and Prevention of Vaccine-Preventable Diseases, also known as the Pink Book. As of August 2014, the PharmaJet Stratus needle-free injection system was approved by the Food and Drug Administration, or FDA, for intramuscular injection. It may be used with one influenza vaccine product, Afluria, but only for persons 18 through 64 years of age. Additional information can be found on the PharmaJet Stratus website. The second route of injection is intradermal. Fluzone intradermal is administered by the intradermal or ID route. This formulation is not the same as intramuscular formulations of inactivated influenza vaccine. This is the only influenza vaccine that should be administered by this route. It should only be administered using the injection device packaged with the vaccine. The third route used to administer influenza vaccine is intranasal, abbreviated NAS. The live attenuated influenza vaccine, FluMist, is the only vaccine administered by this route. Detailed information on the intranasal administration of LAIV is included in the manufacturer's product information. However, ACIP has made the interim recommendation that LAIV not be used this season. What guidance is there for preventing injury if patients faint after vaccination? Since 2005, the Vaccine Adverse Event Reporting System, or VAERS, has received an increasing number of reports of syncope, or fainting, in adolescents and young adults after vaccination. Symptoms that precede fainting include weakness, dizziness, and pallor. Giving patients a beverage, snack, or some reassurance about the procedure has been shown to prevent some fainting. There are measures to reduce the risk of injury from syncope. Falls due to fainting can be prevented by having patients sit in a chair or lie down when they receive a vaccination. ACIP recommends providers strongly consider observing patients for 15 minutes after vaccination. Information on this topic is posted on CDC's Vaccine Safety webpage. Are there legal requirements for what must be shared with patients or documented in medical records? Yes, the National Childhood Vaccine Injury Act requires that a vaccine information statement, or VIS, be given to parents, legal representatives, or adult patients before administering any vaccine. Federal law requires certain information to be documented in the patient's paper or electronic medical record or on a permanent office log. This includes the vaccine manufacturer, the lot number of the vaccine, the date the vaccine is administered, the name and title of the person who administered the vaccine, and the address of the facility where the permanent record will be kept, the edition date of the VIS, which is located on the back of the VIS in the lower right corner, and finally, the date the VIS was given to the patient, parent, or guardian. Best practice guidelines also include documenting the vaccine type using the ACIP abbreviation, route, dosage or volume, and site of the vaccination. Healthcare personnel are also strongly encouraged to document the dose in their Immunization Information System, or IIS. Your facility may require other documentation. Follow your facility's policies and procedures for medical documentation. Our final question is, what are some common influenza vaccine administration errors and what strategies can be used to prevent them? A common error is inadvertent administration of expired vaccine. Always check the expiration date before preparing or administering vaccine. Expired vaccine should never be administered. Other administration errors we frequently hear about include wrong dosage or amount, influenza vaccine administered outside of the product's indications, and wrong route. But there are effective strategies for preventing these types of administration errors. First, educate all staff administering vaccine about the influenza vaccine inventory. Always verify you have selected the correct vaccine to administer based on the product's indications. Store vaccines with similar packaging on different shelves of the refrigerator. Label the vaccine in the storage unit with the age or other unique indications. Check expiration dates on the vaccines on a regular basis. Remove any expired vaccines promptly from the storage unit. Only administer vaccines you have prepared. And finally, use standard ACIP abbreviations. A link to the standardized abbreviations list can be found on the ACIP webpage.
If you or your staff have additional questions, email them to nipinfo@cdc.gov. Continuing education is available for this program only through the CDC ATSDR Training and Continuing Education online system at www.cdc.gov/TCE online. There are two important pieces of information you need to receive CE for this program. First is the course number. The course number for this program is WD2727. That's WD2727. You must also have a verification code to complete the evaluation and post-test. This verification code is 2016 flu. That's 2016, capital F, lowercase lu. Thank you for joining us. It has been our pleasure to bring you this program.